cerebral was more like
cerebral blood vessels, yes. So if you have those tangles or you have extra plaque or those extra beta proteins in your brain, they're gonna make your blood vessels fragile. And how many layers of blood vessels? Two. So that's why they're so prone to rupturing. So I talked a little bit about this hypothesis, this Monroe-Kelly hypothesis, where in our brain we have blood, cerebral spinal fluid, and brain tissue. So our cranium is rigid. It can't expand like our skin can, right? So if our brain tissue is expanding, then one of these have got to give, or both of these have got to give. Vice versa, if we have a bleed, so there's more blood in the brain, then it's going to cause these two to shift. But the biggest thing is we're worried about is cerebral edema or intracranial pressure, because any kind of pressure, and I know I'm getting way ahead of myself, but any kind of pressure in the brain will cause that brainstem herniation, because there's no other place where that tissue and blood goes except for the base of your skull, which is the foramen magnum, and that's where your brainstem is. So if your brainstem is trying to get through that little, probably smaller than that, I'm not sure how big it is, but when you put pressure on that brainstem, and that's where your lifeline is, your respirations, your temperature control, your heart rate control. So we got to protect that brainstem, and intracranial pressure is a big thing that we need to treat right away. So hemorrhagic stroke, you still have the same deficits, and that's the one thing that we'll talk about next week also, is if you have, when we talk about a tumor, a brain abscess, no matter where it is in the world, you're still going to have the same symptoms. So don't worry about thinking, oh, this is a brain tumor is in this area, or it's going to cause these symptoms. It just depends on what lobe it is. So if you have a stroke in the frontal lobe, you're going to have judgment issues. If you have a brain tumor in the frontal lobe, you're going to have the same symptoms. But with hemorrhagic stroke or ruptured aneurysm, they talk about the severe headache, like the worst headache of your life, nausea, vomiting, decreased level of consciousness, and they can have seizures. They'll have pain, they can have headaches, pain, headache. Nuchal rigidity, that means that the spinal cord is now getting irritated, the meninges, so it's hard to bend the. They don't want to move their head. They don't want to even move their neck because it's so painful. Visual disturbances, tinnitus, which is hearing problems, dizziness, photophobia, which is vision or light problems. Diagnostic procedures, again, CT first and then MRI. Oh, there was something I wanted to say. Okay, so decreased level of consciousness. That is one of the first hallmark symptoms of your intracranial pressure, is decreased. So what are some other ways that I can say decreased level of consciousness? And it will go
Altered
all the way
mental
back
status.
to, what?
Altered mental status.
Confusion.
Lethargic.
Altered mental status. Oh,
I said.
Restlessness, anxiety, sudden drowsiness is another key, like NCLEX phrase that they use. Irritability is another one. Those are some key terms where you come into the room and they'll say, oh, your patient has sudden drowsiness. You should think, oh, they got intracranial pressure or something like that. That's my first thought. Or that all of a sudden they're restless. Oh, they're going to have intracranial pressure. Now where do I go?
You're on fine for
There. So, CT, so now we're bleeding in the brain, some complications because blood is an irritant to our brain tissue. They can have vasospasms within the brain. So your vessels are now having spasms. And so if they start to contract or, get smaller in size, contract, they're gonna have further pain, so we'll give nimodipine, which is a calcium channel blocker, because that will kinda keep your vessels from contracting and dilating. It will keep a kind of a smooth vessel, from occurring, or keeping that. So, and also is, those vasospasm will increase the risk of, not bleeding again. Aneurysm precautions or bleeding precautions, you're gonna see a lot of stimuli, environment, no TVs, dim lights, not a lot of noise, and if you can think about, some of these patients are in ICU, think about all those not many call lights, but all the alarms, all the ventilators, they make a lot of noise. That's not good for the, patient with a hemorrhage stroke, because we wanna decrease the stimulus. Close the doors, close the curtains, restrict visitors, maybe only have one visitor at a time. No constipation, because if you start straining, and I'm not gonna do it right now, but if you think about it, when you're straining, it increases your intracranial pressure. So no straining, no coughing. And coughing increases your intracranial pressure.
No vomiting.
We talked about suctioning earlier, we'll get into that a little bit, but that increases suctioning from the vent increases your intracranial pressure. So when you think about intracranial pressure and hemorrhage and all that, we gotta make sure that we decrease that stimulus. Another type of therapy is this triple H therapy. It's kind of, not new because it has been, but it's like, let's trial and error, where they're gonna do fluid expanders like your albumin, introduce any kind of, arterial hypertension, because again, we wanna keep blood flow going to the brain, but we also wanna stop the bleeding that's occurring. So, and then you're gonna dilute that blood also, so with, fluids. So it's kind of this balancing act. We gotta stop the bleeding, but we gotta keep blood going there, because we gotta keep the brain tissue from perfusing, because it does create this critical event. Cerebral hypoxia, because there is a bleed going on, so not all the brain tissue is getting the blood, so we have to maintain that hemoglobin and hematocrit. Like I said, improve your IV fluids to improve blood flow, decrease viscosity, that makes it a little bit thinner to get blood to. Avoid extreme hypotension and hypertension. There'll be clear guidelines for that, because we gotta keep perfusion going to the brain, and then monitor for seizure activity. Because seizure activity, anything with the brain, whether it be for stroke, tumor, whatever, you're gonna be at risk for seizure activity. So here's my little slide on intracranial pressure. It's like I said, the opposite of shock. The first signs are decreased level of consciousness, restlessness, drowsiness. But with increased intracranial pressure, you're gonna have the increased blood pressure and decreased pulse respirations. The three of these together are Cushing's triad. That's what it's called. You can have other things in there, like a narrow or widened pulse pressure, sorry, wrong one. A widened pulse pressure. But we talked about a little bit before lunch how to reduce intracranial pressure, mannitol, Etabed, glucose, hypertonic solutions, because we want more, we want to switch that fluid, get into the vascular system. And you can control your hypertension with nicardipine, labetalol, hydralazine, stool softener, because we don't want to have an increased intracranial pressure. Some treatments for intracranial bed rest, sedate, because we want to prevent say they're on Coumadin, we wanna give an antidote. Prodexa, we can give an antidote. So we always gotta find out, why are they bleeding? Did they fall, hit their head, they're bleeding, their fall, hit their head, they're on Coumadin, they're bleeding. Why are they bleeding? Why do they have the hemorrhage? If they're having a seizure, we wanna give them Dilantin. Avoid, like I said, avoid those hyperglycemia and hypoglycemia and hyper SCDs, because we wanna prevent blood clots. Some of this stuff is kind of, you guys should already know, like anesthetic, like Tylenol for pain, ice, salines, cooling blankets, depending on their temperature, because we're worried about intracranial pressure, we're worried about that brainstem herniation, and when that brainstem gets involved, they're gonna have abnormal temperature control, so we're gonna use cooling blankets or warming blankets, depending on what their blood pressure is. And then relieve anxiety. So that Ativan, we already know that. With worsening neurological conditions, maybe the bleeding is not stopping, so now we're gonna move into, okay, we gotta evacuate this blood. We need to do craniotomy, which are burr holes. So in the skull, they're gonna drill all these little holes. They could put medication in there, they can put monitor catheters in there to just check how this intracranial pressure is going. They can remove a bone flap. I might have a picture a little bit later, but this is a life-saving procedure to remove any kind of blood, to release any kind of that intracranial pressure. But like I said, there's risk. If you think about it, look at, there's infection control we're looking at now. Seizures, we're worried about seizures. Any further neurological deficits with this. Other things, say they can go in and do clamps. Like say they're bleeding from an aneurysm. They can actually go in and put in clamps to flip it off, or I should say clips, they're called clips. Before rupture, they can actually fill it in with a coil, and what happens here is the blood starts to coagulate here and clot, so it doesn't put any more pressure within that aneurysm. I was gonna go there to, you guys have a question about that? The thing is, and this will be nice for next week also, is anything within the brain, whether it's stroke, tumor, any spinal cord injury we're gonna talk about, brain abscess, whatever it is in the brain, they're all gonna have the same complications. Your book and ATI, they keep on regurgitating all the same complications. But think about the brain, they're all gonna be at risk for intracranial pressure, they're all gonna be at risk for infection, they're all gonna be at risk for hemorrhage, yeah. The fluid and electrolytes, if you think about it, the pituitary gland is right there in the middle of your brain, right? And you guys learned about any pressure on the pituitary gland from last semester with diabetes insipidus and SIADH, all that comes back into play again. So you're monitoring your electrolytes, urinary output, and all that to make sure that you're watching for those. I know I went way back past where I was going. Rebleeding, we're always assessing during those neurological assessments to see, are they getting better or are they getting worse? Hydrocephalus is another one where you have this downward deviation of the eyes, where here's the cerebral spinal fluid. So if there's a shift in brain tissue, it might block some of the filtering, and you might have an increase in cerebral spinal fluid, but a hallmark sign is this downward deviation. They're looking at their nose. So that's a hallmark sign of hydrocephalus. What did you call it? Downward deviation of the eyes. Is that what you're asking? the plaque is building up, so you have a slower onset. What lobe of the brain if I have blindness in one eye? Occipital lobe, right? What is it when symptoms resolve within 24 hours? TIA. What can we educate, what kind of education will we provide to a person that has an increased risk for stroke? Am I gonna put decreased risk factors?
Be fast.
Manage diabetes, manage hypertension,
Stop
manage
smoking. No smoking, no drinking.
no smoking, I turn it over here, cholesterol.
Diet.
Do I want a full fat diet with sausage? and
No.
bacon,
Yes, I do.
McDonald's, French fries? Am I gonna hydrate myself with Trulies?
Oh.
Flavored water, my flavored water, Trulies. So make sure you're educating on all that with TIA. What may be occurring when a patient is experiencing a severe headache, nausea, vomiting, decreased level of consciousness?
Hemorrhagic stroke.
Hemorrhage, rebleed of or a bleed of an aneurysm, but they're bleeding in the brain. What kind of stroke am I having from a head trauma? I don't remember this one.
Stroke from a head trauma.
What type?
Probably
Ischemic or-
hemorrhagic. Probably hemorrhagic. Probably gonna make you bleed.
That's where my brain is going now. Where's my stroke if I have a respiratory rate of 3? I can only say 5.
Or rate of 3.
Frontal lobe, what specific area?
Broca.
Because my speech is broken. What about ataxia? I'm tripping over and falling. Your cerebellum. Where's my stroke if I have right hemiparesis?
Left-sided,
So
the
what is
brain.
hemiparesis?
Half of your body has
Paralysis.
Hemiparesis,
The
what does
tingling.
paresis mean?
paralysis.
So your paralysis on right side.
That too.
So you're right, correct.
You got it.
It's the left-sided stroke. What happens where's my stroke if I'm thinking I'm 40 years younger than I
I
am?
don't have a stroke, but I think I'm in my 20s. That's normal.
Frontal lobe, judgment, yeah.
Dang, Tito, you're getting a job, Tito.
Good job, Tito.
Alright, left hemiparesis, where's my stroke?
The right.
Okay. Has trouble writing their name on a registration form.
That's
That's
a
like the
parietal.
coffee maker lady, right? That you said?
That's parietal.
No.
Writing.
Fine motor skills, where's that? Cerebellum.
Yes.
We did have this happen and it was our registration form where they just noticed their signature was different from when they came into ED and when they were leaving, and noticed that there was a drastic difference in signature. And the person was having a stroke while they were there.
Oh,
Can't
well,
see
yeah.
the chart.
You can see the beads and you can see the age.
Pardon me? Yeah, it could be parietal lobe. But coordination, fine motor movement. Does not, what side, right or left, does not realize they are leaning in the left sitting position. So they're leaning. Correct. Facial difference. Does not understand what is being said to them. The Wernicke, what lobe?
The bottom one.
Dang.
Temporal, right in W. Temporal, your temple is here, it's just straight in. But that's not what because the W, you told me W. No, your bottom one is your brain.
So, traumatic brain injury, like I said, wherever the deficit is, it's the same kind of stroke. You'll be able to see where the traumatic brain injury is because they'll have those same symptoms. So, the problem with brain, there's something called primary injury and secondary injury. But So the primary injury is considered the force of the blow. Did they fall? Did they have an accident? What happened to cause that brain trauma? The secondary injury is that increased intracranial pressure. And really sometimes that's the one that we worry about the most, is because the structure and all that we can manage, but that intracranial pressure is really what we're looking to, is the more critical part of it. But with traumatic brain injury, it's an external bolt or jolt to the head. Normal functioning of the brain is disrupted. You could have short-term, long-term deficits. I'm not going to go into that much. So rebound or rotate, there's a counter coup and coup injury. So if you think a patient falls, they fall and hit their head here. So because of that cerebral spinal fluid, their brain is hitting on the right side, but because it's so buoyant, it's going to rotate, not rotate, but it's going to bounce back on this side. So they might have two head injuries. They might have this side and this side. So if you think about someone falling forward, they're hitting their head forward and they're hitting it back here. Bruised, torn, because our cranium is it's not smooth and nice and pretty inside, it's very rigid and jagged, our skull, so it can get torn pretty easily, so we gotta really protect it, and that's why we have the cerebral spinal fluid. And like I said, usually the frontal lobe and temporal lobe are what is being injured mainly because of falls. I don't know why I keep pulling on that. So same thing here. If there's increased bleeding, someone's gonna have to give. We're still putting brain tissue, pressure on the brain tissue, and the cerebral spinal fluid will have to adjust also. Risk factors, wear helmets. I'm bad about this, especially riding a bike or skiing. I'm getting better. But motor vehicle accidents, make sure motorcycles wear their helmet. Drug and alcohol use, sports injuries, assaults, gunshot wounds, I like those. And falls. All these are safety. Make sure we're safety. Don't go riding in the back of a pickup truck. So you people that live out in the country, so safety, protect the head. So like I said, the primary injury is the actual insult, the fall, the whatever happened. The secondary injury can happen days, few hours, few minutes to days. It's mainly that intracranial pressure, cerebral edema, whatever is going to happen. So during the, I'm going to go into this. So at the time of injury, I'm not going to worry about scalp injury. This is sometimes called battle scars or raccoon eyes. You see the bruising around the eyes or behind the ear there, the mastoid. Those are indications that there's been skull fractures. So we're concerned about that when we see this. And then we're going to be going to test any kind of clear drainage out of their nose and ears, because we're going to test for cerebral spinal fluid. But back to injuries, you can have a skull injury. Has anyone had a, like, cut their head open or something? A lot of blood. Your blood, I mean, it's highly vascular, it bleeds, it looks horrible. I remember taking my son to the emergency room and I was like, you're a dumb idiot, Harry. He needs to go to the emergency room. He had such a little, he fell and hit his head on a rock. And I was right there with him. I didn't push him. It literally looked like the smallest cut, but it bled so bad.
Yeah, my son cut him so when he was like 3, running down the hallway at an apartment, fell, hit the corner of the blood everywhere.
Non-emergent care was not open yet, so I had to sit there for an hour, even though I was an employee there, which didn't really matter. And he's like crawling up and down the chairs and all that, and I'm like, why am I not leaving right now? I should be leaving, but I did. All I did was a little derma.
Mine got stitches inside and then outside.
But I did. But there's a lot of blood. It's alarming how much blood comes out of your head. different skull fractures. The one that I worry about is when they don't have a skull fracture. Because what happened, yeah, because where does the swelling go? It doesn't go, it goes down the foramen magnum, which is gonna put pressure on that brainstem herniation. So at least if you have a skull fracture, the swelling will be released a little bit. It's not gonna go downward. So if there's a fracture, it is what it is, we're gonna take care of it. But if they hit their head and you see all these symptoms and there's no skull fracture, all that increased intracranial pressure is one way to go, down. And that is a medical emergency. Diagnostic, again, CT, MRI. So there's closed and open, which is pretty much what I just said. Closed meaning that the head is closed, open meaning that they have a skull fracture, their head is open. Basal skull fractures is at the base of their neck. The bleeding or clear drainage can be coming from their nose or their ears. Like I said, battle signs. Hematoma is bleeding in the brain. But when we talk about clear drainage from the ears or nose, we want to check for glucose because cerebral spinal fluid has glucose, right? But our nasal drainage does not. So we're checking our nasal drainage for cerebral spinal fluid, and I think it's coming up. It will be coming up. But, so that's why we check, because if we're checking nasal drainage and drainage out of the ears, it tests positive for glucose, then we know that they have a fracture, their cerebral spinal fluid. So categories of trauma, concussion is usually mild, shaky movements, symptoms, if they have neurological symptoms, usually resolve within 72 hours. Now this whole football and helmets, I mean, there's getting a lot of regulation on head injuries with sports. Contusion is a bruise, and like I said, this counter coup and coup injury, they fall, hit their frontal lobe, and then it's bouncing back and hitting the back of the head also. So you have this counter coup injury. Diffuse diaxonal injury or axonal injury is where actually the twisting of the brainstem and the neurons get severed. So there's no communication between the brain and the spinal cord and the rest of the body. It's immediate coma. You might see decorticated or decerebrated position. And those are never good. I'm not seeing anybody. In a good way, if they do, they got some problem. I have seen, no, I haven't seen anybody. The one person that I'm thinking of, I think he died. Pretty sure he died. I know, she asked a question. Yes.
What's the difference between counter coup and like whiplash?
Not much different because it's the same, the whiplash, you're coming forward and then going back. It's that same type of thought process where your brain is hitting the forebrain and then the back brain.
What's the difference between like contusion and hematoma?
Hematoma is actual bleeding, where contusion is it's just bruise. There's no actively bleeding. Could it turn into actual bleeding? Yes.
So would these people be like brain dead? Since they're like immediate coma, don't they?
Yeah. Yeah. I've seen this happen because, I shouldn't say this.
We can hear it.
Say it.
There's probably many
boo.
people with this.
Because you guys remember, okay, so someone's in a car accident and they're automatically doing this, because usually this happens with high-speed accidents. They're automatically doing these positionings. The one that I'm thinking of that when you asked do they survive, this guy that I know, he survived a couple days, but I think he eventually died. I was done working, so I don't know what happened to him. And I didn't ask. headache dies right away, it's because of this. They fall from high distances. Something happens. Something happens that shouldn't. All right, clinical manifestations, as I said, basal skull fracture. So this is a sign that on your dressing is cerebral spinal fluid liquid. Do you see this kind of like yellow halo around blood? That's an indication of cerebral spinal fluid is leaking. So you see this halo around blood, or it might be all yellow or clear. So you definitely see a halo around blood. When we get into intracranial hemorrhage, you're looking at the epidural, subdural hemorrhage, but no matter where it is, it's still putting pressure on the brain tissue. It's still compressing that brain tissue. So you're still going to have neurological deficits somewhere, somehow. Say it's the frontal lobe, depending on where it is. Usually if it's a hematoma or bleeding, you have this midline shift. I don't have a slide on this, but your brain hemispheres comes down here, right? So usually if there's bleeding in one area, you might have this shift move over if there's bleeding here. And when you have that midline shift, you know that there's going to be a poorly neurological condition. Like here's the middle of the brain. Usually this line is shifted over and there's transfer bleeding in one side or the other. That's nice to know. And if we see it, it's going in and out. So intracerebral hemorrhage is when there's bleeding going within the brain tissue. This usually comes from an aneurysm or a rupture of something, usually the intracerebral hematoma. But again, intracranial pressure, we're going to be monitoring for that. To make sure that we recognize this as soon as we can. And what's our first indication of intracranial pressure?
Widen pulse, high blood pressure.
Level of consciousness.
Oh, still? That too, we knew that.
Irritability, restlessness, anxiety is too vague,
Everybody's in
sudden
the
drowsy. So here's our little guy, he got bumped in the head.
Wow.
So he's gonna have increased
He's got a bump.
drowsiness, confusion, seizures. None of this should be surprising. Pupils, so that's why we're checking our pupils. You're looking at those cranial nerves. You're gonna see, you're not gonna see perla. You're gonna see abnormal pupil dilation or accommodation. I know that, this goes back years. We had I think less than a 2-year-old came, well, they were walking, so it could be still that age. Came into the ED and they had their pupils like this. But we found out from the father that this had been a problem. They've been with the neurologist for a while. But girlfriend is in the waiting room telling everything about what happened, where they had pot and the kid was getting into the pot and it was a mess. But this was not the problem. The pupils were not the problem, but the sticking the baby like multiple times to get an IV and the baby's not crying.
That's weird.
Something's up.
Oh.
So they did Narcan and that baby started crying. So we think the baby started getting into something.
Wow.
With the girlfriend, we had the dad in the ED room telling his story, but the girlfriend was in the waiting room telling her story, and the nurse was in there. Both of them are writing notes on what one is saying and playing off each other, and we got down to the bottom of it. And of course, I was standing in the room watching all this transpire.
Oh, that was a good day for them.
Somebody hold her back.
I know, I would not have been good at like pediatric nurse.
Me neither.
Kidnapping, all the babies, because they don't need them. I know you're all recording it, I just said that as a joke. So, in traumatic brain injury, when you're in the, field, any suspected, and I'm looking at Justin again, get them on the backboard, cervical, T-collar. We want to protect the head, we want to protect that spine, we don't want any further damage. Put them on the backboard. Put them on the backboard.
We try not to use backboard.
So,
Because it causes more damage to the prime.
yeah, don't listen to him. Flex, and Mrs. Dowling will say, get them on the backboard. Because we gotta protect that, neck, we gotta protect that head. We don't want it just flimsy going all over the place.
What about a neck brace?
Well,
Sorry.
but that will keep their head, the cervical spine, that's what it is, the cervical spine. We gotta keep it in place until we get visual images of what's happening. And the doctor confirms that they are, everything is intact. And when we take them off, there's like 5, 6 people, like, you have to document who's in the room, who's doing what. This is just nice and good stuff. But you have to document who's in the room, what position everybody's in, taking somebody off the backboard because of the legality of it, and the doctor has got to prepare it. So if you're working in the ED for my ED people here, you don't, like Justin said, you don't want them on the backboard too long because it does cause more injury to their skin and stuff. But, God, sometimes they're like still moving around if they're drunk or something like that. But, you wanna tell the doctor, look, results have come back, can this patient come off the backboard? Usually you can come off the backboard, you just gotta maintain alignment until further testing. Yeah. Unless it, keep the head of bed up, unless it's contraindicated. There's always a disclaimer. I know. So, there's abnormal breathing when we're suspecting somebody of a head injury. I want you just to recognize it, that these are abnormal breathings, like the chain strokes, respirations, where they have rapid respirations and then kind of a long pause, have apnea. So Kussmaul breathing would be another one. Tachypnea, you guys know what that is, and bradycardia, or bradycardia. But no, just recognize these, that these would be abnormal
These are
breathing patterns. I'm not gonna say, okay, what is chain stroke breathing pattern? You're also gonna do your Glasgow Coma scale again. Good information. When did the injury occur? Was it a fast accident? Did they get hit by an object? Did they fall? How far did they fall? How many feet did they fall? Am I speaking right? 6 feet, doesn't need a back collar. Did they fall off the back of the truck? They don't need the backboard, I should say. Direct blow was a direct blow and a direct blow. Level of consciousness, how long were they out? Were they out for a minute? Were they out for 5 minutes? Are they still out? So some of these questions are what we need to know to confirm a diagnosis or to suspect injury. We talked about the abnormal procedures, but any kind of brain injury or complications, here they are again. Your diabetes insipidus, your syndrome of inappropriate antidiuretic hormone, because of that swelling in the brain is putting pressure on the pituitary hormone. So we're gonna be looking at this. We'll probably need some vent support, oxygen, so propofol, we're gonna give medication. Prevent seizures, what medication are we giving for that?
Then 20.
Seizure medication.
Dilantin, anxiety, benzodiazepine,
What did you say?
pain, Tylenol, which
What's the
doesn't
name?
want. Prevent agitation, anything like that. So you're gonna see the same pattern of complications for a brain injury.
That's for the people that are.
So is benzodiazepine a challenge pepper as well? Is benzodiazepine, they're benzoes, are those calcium channel peppers because it
So
is.
on. So intracranial pressure, that one thing that I added here,
That's for
I
the.
added more here. I kinda got a little
That doesn't end
crazy.
in time. The benzo's
Drowsiness,
ended in
confusion,
time.
lethargic, I didn't say that earlier, but that's why I put it up here.
10.
Stupor, I know. Widened pulse pressure, I did mention that earlier, but and then increased temperature.
I just know the benzo's.
So all those are indicated, you need to know intracranial pressure, signs and symptoms for the test? Good idea. Cerebral
Oh, you're right. But no,
response to
those are the
intracranial
benzos.
pressure, so normal
Those
cerebral
would be I-
pressure is 60 to 70, like we have our own pressure within our heart. Intracranial pressure, same thing, is below 50. We have Cushing response. Cushing response is when the cerebral blood flow decreases. And then if cerebral blood flow decreases, what's happening to that tissue? It starts to die, it's not getting the nutrients, it's not getting the oxygen that it needs. So then you have this increase in systolic blood pressure, and then you have the widening pulse pressure. Then your cardiac starts to slow down and your breathing starts to slow down. What are those the symptoms of?
Increase.
It's really easy, well, I don't wanna say it's easy,
Or
but
increased
just
ICP.
when you see something like this, just slow it down and go, okay, what do I know? What do I know about ICP? I know increased blood pressure, and just take it one thing at a time. Because when we wanna recognize these symptoms, because we wanna prevent this, we wanna prevent brainstem herniation. Because you could see here, see how the brainstem is starting to go down, or the cerebellum is starting to go down into the spinal cavity there? Can you see that on the picture?
No.
What's CPP?
Cerebral pressure within the brain, like just like your blood pressure, that's in the head. Did you guys see where that red part is going down into the spinal, through the
Yeah.
brain? Because if you see that, here's this other belt, look at all the pressure that's going on in that brainstem. Because if we keep on keeping pressure up here, it's all gonna start to go down and causing that herniation, which literally ceases life. Not throwing everybody down. So, it could, yeah, so if you do have a fracture in the brain, you're bleeding, or you have, say, cerebral edema, instead of the tissue going down, it's gonna, it can expand that skull or wherever that fracture is, so it's not all going down. You don't have other deficit, yeah, it's messed up. You're still pretty messed up. It's better.
Better nothing.
Okay, this doesn't, so, I'm not worried about this. So cerebral edema, so more fluid is accumulating in the our brain tissue. So mannitol, I talked about that. One I didn't talk about yet was dexamethasone. That is a steroid. So that's a steroid that decreases the swelling, or inflammation. So it will decrease inflammation in that brain tissue. So dexamethasone, hypertonic saline solutions. So that is, if it's hypertonic, it's pulling in through osmotic because we don't wanna shrink that brain tissue all the way, we just wanna pull a little bit of the fluid off. So there's really a lot of restrictions that you can, do with 3%. One time, this was back years ago, I don't know, a lot of years ago, but it was like on the regular CTE floor, and I was going through something, and I saw 3% saline, and I'm like, wait, wait a second, why are we doing that? First of all, that should not even be in our pharmacy here at UBMC, because they should be in Miami Valley. They shouldn't be. It was, I don't know what happened, but I just kind of flagged it, and I was like, you need to talk to a doctor about this, because this is not the right order for this facility. But, yeah, so hypertonic, we want our fluid restriction to reduce that edema in the brain. Management, monitor vital signs, head of bed, head midline. Remember, I want to promote that venous drainage. I want to promote that fluid. Anything that makes it easier for that fluid to remove. No coughing, no sneezing, no straining, no suctioning. Maintain that respiration. We're looking at I's and O's. Most likely this patient's on the vent if it's not bad. I's, no meds. We're preventing hypothermia, because what happens when we're cold? We shiver. When we shiver, it
Mid-site
increases our
pressure.
intracranial pressure. So, decrease stimuli. And then we're monitoring. We got a student couple, and I have her pictures from her son. Her son had something, and he had a lot of surgeries, and she took like 5 minutes, 10 minutes out of the lecture and showed pictures of his son, and he had like wires, but he was up walking in the hallways, he had all these wires coming out of his head, and I'm like, oh my God, scary. But draining blood, make sure you're looking at those complications for infection, vascular collapse. So you don't want any of these areas to collapse, those catheters, or the catheters can become occluded, just like our catheters in our IV veins. You don't want them to occlude because they gotta administer medications. Some of them are monitoring that pressure and everything. So maintaining cerebral perfusion. So we talked about some medications
Turn it
and
off or
Butyrex.
something, disconnect it.
So I'll tell them about it.
Yeah, because for the test, it'll be kind of.
So maintain your perfusion. You might have to give some medications. Hemicraniotomy. Maybe we're looking at removing part of the skull so we can have that brain tissue expand. Surgical. Okay, this is what I want you to know. Surgical to the head. No matter where it is, it's divided into two areas, supratentorial or infratentorial. So our supratentorial is in the cerebrum up here. Our infratentorial is pretty much our brainstem and our cerebellum. There's a tentorial line right here between the cerebrum and the cerebellum. This line right here. And how you position the patient after surgery is important to know. Okay.
What did she say?
So cerebellum and what? The cord? No, there's spinal cord, was it the brain, the bottom one? Sorry, you're going really fast.
The tentorial line for brain
What's the
surgery.
The bottom, but like, what's it, you said it's included.
Cerebellum and the brainstem are in the infratentorial. And this should be, I should have a slide on this on Blackboard also.
Wait, so what's the other
So
one?
preoperatively,
Wait, Miss Downing, what's the other one?
supratentorial,
No, that's all the other parts of the brain, like the temporal, frontal.
you pretty much have your lobes up here, right? Supratentorial. Then you have the tentorial line. It's the cerebellum and the brainstem.
Oh, okay.
Below. So pre-surgery, someone's going into surgery, they're gonna get drills in their skull, not fun. So remove, indications for brain surgery, remove tumors, relieve intracranial pressure, remove any blood clots, remove or control hemorrhage. Pre-operative and decrease any anxiety, Valium or Ativan. So all of these you've already seen. So preoperatively we are doing that, postoperatively also. Okay, so supratentorial, this is brain to the upper, above that tentorial line. We want to keep their head of bed up, at least 30 degrees, unless it's contraindicated. But head of bed up, no extreme hip flexation or neck flexation. We want to keep the headline, midline, and neutral because we want to promote that venous drainage. Infratentorial is we keep the head of bed flat. The patient's on their side, and we keep them NPO for 24 hours. And I always think infratentorial, it's below, so that head of bed is below, is flat, not below, but it's flat. So supratentorial is above, keep your head of bed up, 30 degrees midline, no extreme flexation. So that's how I remember the difference between the two. And yes, it would be a good idea to know this. That's why it's in red.
Can you go back to the other one?
Start, highlight it.
Can you go back one more time?
So,
Go back to the other one before that one.
the,
That one. No.
all right, we're meeting, aren't we? I think I'm meeting it. We'll go over the slides. All right, post-op, guess our post-op. Vitals? Electrolytes? Right? Because we're worried about what? Our diabetes insipidus? We're worried about infection? Think about post-surgery. What are we worried about? All this. Bleeding. We're looking at the drainage because we just drew holes in your skull. So we're looking at the drainage. So we want to look for cerebral spinal fluid. Is cerebral spinal fluid leaking? So we're looking at those dressings. Is there a yellow halo or is it, what is it? Infection. So what about our infection? We just drilled holes in your skull. So proper wound care. Meningitis, mainly because of infection. And then syndrome of SIADH and DI. Ready? So review it. So there's our dressing changes. Report immediately if you see neurological problems. So any of our neurological issues. Cerebral edema, these aren't new, but that's a complication, right? Manage pain and seizures. So I feel like it's this revolving thing with neuro. It's like, it's the same thing over and over. Post-surgery, though, this is the only time, if they get periorbital edema, that is normal post-surgery. Periorbital edema, right there. So, it is not unusual. So sometimes in rehab, someone's had brain surgery, they come to rehab, and then all of a sudden, like 2 days later, they're starting to get, this guy one time had swelling, bruising around his face, and their family was concerned, he was concerned, but I'm thinking about, I'm like, okay, when you have surgery or injury, you get swelling, right? You get drainage, you get bruising. Same thing that he had this, where is the drainage going? It's going to his face, it's going to his eyes. The bruising, it's all, that would be all normal. This is all the same. Brain death. There are 3 cardinal signs to brain death: coma, and then absence of any kind of reflexes. So you do your reflexes and no breathing. Usually they do 2 tests, or 2 doctors have to confirm brain death before they do any kind of withdrawal of treatment. I want to get into spinal cord injury. Because there's 2 complications. You already know one.
Airway.
Airway. So your cervical region is usually,
Breathing.
it's called C3 to C5, keeps the diaphragm alive. That area innervates the diaphragm, so that is our respiratory control center. So when we have a spinal cord injury, we need to stabilize that spinal cord. That's why the back cord is important. The back cord and cervical column, keep that in line. We gotta keep it all in line, so we don't want to cause further damage. Yeah, I got a slide.
That writing in red, is that important?
Huh?
The writing in red, is that important?
Probably if it's red. Oh, younger male. I just probably can't see the red. Classifications, again, you have your contusion, your lesions, compression of the cord. There is complete spinal cord, tears or incomplete. And that's the thing with the spinal cord is we really don't know what symptoms you're gonna have until the patient kind of tells us what they're having. Because our spinal cord, we have our messages that go from the brain, we're sending motor messages through the spinal cord to move our legs, move our arms, do whatever, to do something. The sensory signals are coming to the brain. So if you have an incomplete spinal cord injury, we really don't know what you're gonna have until the patient kind of tells us, can you feel this, can you move this? So during those neurovascular, or not neurovascular, but those neural assessments will help with diagnosing what their deficits are gonna be. So this is the picture I was thinking of. So cervical, we have 8, thoracic 12, lumbar 5, sacral 5. And I always think of my five-year-old. My father-in-law or elderly, they always want to eat at 8, noon, and 5. And then 5 hours later, they have a snack. So that's easy to remember. But the priority is our respiratory. So C3 to C5 keeps the diaphragm alive. We want to, that would be our priority, easy as that. But as you move down the spine, it starts to innervate a little bit more than just like legs and arms. Arms come down a little bit further. Groin till where it's like your bladder, your rectum gets involved, your abdomen. I had a brother-in-law, he had a C7 he fell out of a tree stand, and he had probably an incomplete, but I think they diagnosed it as a complete severed, but he did have sensation, like he could feel when I touched his foot or touched his leg, he could feel that, but he could not move it. So he had a C7. He had trouble like sitting, he would always be hunched over, he'd always have to like lift up his chest. He was able to move his right arm, he was weak in that left arm, and he was left-handed. But he told paralysis pretty much from chest down. But ABCs, get him on the backboard, prevent, get a CT, MRI, X-ray. Assessment, we want to assess breathing pattern and strength. So they might be breathing, but do they have a strong cough? Motor ability, have them move their fingers, have them spread their fingers out. Can they squeeze their hand? Do all those movement tests. Can they turn their toes? Can they push? Like I always have patients when I go, okay, push on my hands like a gas pedal. Just test their strength. Sensation, can they feel sensation where I'm pricking them? So this is all information that tells us what type of spinal injury they have. Bladder distension, do they have urine building up? Do they have ability to urine? Do they have the ability to have a bowel movement? So all of this will tell us what kind of care they need also. Temperature control, so they might have periods of hypothermia or hypothermia. It just kind of depends. In the acute phase, we're going to get into that high dose of cortisone Because if they have, say, we'll go back to my brother-in-law, he had a C7 fracture, or, so everything below that C7 is now not getting perfused because you think that edema and swelling, so they wanna decrease that swelling as soon as possible to get the rest of that spinal cord perfused to try to regain any kind of function. So usually after a spinal cord injury, someone's getting Solumedrol, 24-hour infusion. Oxygen, that's our priority. If the injury is higher above the level of C3 to C5, like a pacemaker, there is now something that's the diaphragmic pacemaker, where it actually contracts your diaphragm to have a respiratory cycle. Doing good interventions. Immobilized, so we want to keep that, if they have surgery, this goes with, like we probably talked about, the bucks traction. Same thing with the brain, or with the head, to maintain alignment. I know that's blurry, but a halo, there's classic halo questions on the NCLEX, or when you do your ATI or prep view. You want to check the skin underneath the lamb's wool, check the pins, like external fixation, check for infection. You don't ever want to use these devices to lift the patient up in bed. I know that sounds like common sense, but you never know. So never pull on them. Make sure these weights are free and clear. They're not laying on the floor. You don't walk by and actually kick them. So there's certain steps that you need to make sure as a nurse. Then surgical management, we want to just maintain alignment with the surgical. So they'll go in and they can put rods in to keep their spine maintained. So one of the first complications is our neurogenic shock. I did talk about this already. So there's a lack of communication. Remember, this feels like yesterday, doesn't it? With the autonomic and within the autonomic nervous system. So you're going to have venous pooling. You're going to have vasodilation from that lack of communication. So that's why you have the bradycardia, low respiratory rate, and hypotension. I didn't think about it before I said it all. Warm, dry skin. Remember all that? You guys remember all that from a couple weeks ago? Interventions, go with your ABCs. Mobility, make sure we, proper alignment. I'm gonna just kind of go through these, because there's one I wanna really talk about. Prevent any injury. One thing that they talk about, or, I'm gonna get it over here, I know I have a slide on it, but they're, orthostatic hypotension, kind of the same thing with the spinal cord injury person, because they don't have the muscular, their vessels are not, they don't have the strength, so when they start to stand up or get in an elevated position, all their blood pools to their feet. So they're, because of that sympathetic miscommunication, their vessels don't have the strength to get the blood back up to the brain. So usually with patients with spinal cord injuries, you might be laying them down at first and then sitting them up. And it really does take time to get them into a standing position. Usually they do get in a standing position with therapy. An abdominal binder, they'll put an abdominal binder on them just to tighten that to help with compressions. They have thigh highs on to help with that problem also. Skin integrity, you can figure that one out. Urinary elimination, they gotta pee, right? They don't have the muscles to pee, so usually they're straight capping them every 6 hours. My brother-in-law, he had to cap himself 6 a.m., noon, 6 p.m., and at midnight. So 4 hours a day he was capping himself. Bowel function, they have a bowel movement. So every night at 8 o'clock, he would go and driving, he was able to drive, he was able to cook for himself, do everything for himself, so, I mean, he could live independently. Comfort, provide comfort with traction, again, just keep those pins if they're in any kind of traction. The halo devices and the cervical tongs, those are temporary, those aren't lifelong. But, lifelong problems, you're looking at the elimination of bowel and bladder. Because this is considered a medical emergency, is autonomic dysreflexia. This is when there's inadequate communication between the sympathetic stimulation and the parasympathetic. So there is a trigger. So the triggers are the patient is constipated, they have fecal, something's going on above. So they might be impacted with fecal expression, they might have pressure injuries, they might have a full bladder because they gotta cap themselves, right? They might have restricted clothing, might have a tight belt, they might have tight socks on. So what happens is they have an extreme elevation in or blood pressure. So their blood pressure is like 200 over 100. It's pretty high. Their face becomes very red. They become sweaty. And you can see this little guy in the wheelchair. Flushed face, headache, distended neck veins. Heart rate is low though because the brain gets to do what it wants in the spinal cord. Increased sweating. But below the level, so lower, their legs are usually pale. They are usually have cool extremities. They might have goosebumps.
Hairless.
Pardon?
Hairless.
Well, they don't, that's more of a chronic problem. But in the acute problem, yeah, cool and no sweating. So what we do as a nurse, we recognize, we're looking out for it, we see, okay, they have a spinal cord injury, they've got an extreme high blood pressure, their face is flushed. We're gonna sit them straight up. We're gonna raise their head a bit. I don't like calling the doctor, but we have to determine the cause. Usually it's just going in and emptying their bladder, emptying their bowel, and that's going in and emptying their bowel, unfortunately. Assessing their skin, do they have any injuries? And now I could say this again, my dumb brother-in-law, he was blowing the leaves off his lawn with a gas blower and go around in his wheelchair. But in the meantime, he put the gas blower on his lap, drive to the next spot. So he didn't realize he had third-degree burns on his legs because he was doing that. So I could call him something. Monitor vital signs, assess skin, administer hypertension meds. But our biggest thing when we experience autonomic dysreflexia, we want to sit their head up and determine the cause. And usually it's a distended bladder. Check their bladder. Do they have a Foley? Is it kinked? Again, do they have stool? And this is a lifelong problem. This happened, they have to live with this. So he knew that when he started getting flushed that he needed to go cap himself or something. So he knew, he's like, yeah, I'm getting a little warm. I better go empty my bladder. So they are educated on that, and it is a lifelong problem. And this is a medical emergency. I did say that, right?
No.
So this is like final stuff too. So this test and the final. Just saying. Other complications, because they're in a chair, they're not moving. So blood clots, we gotta worry about blood clot formation. So now they're on some type of anticoagulant. So do range of motion exercises. Anti-embolytic stockings, he never wore those, he hated them, but it is what it is. But he got a couple blood clots. Hydration, SCDs, postural hypotension, that was what I was talking about. They have these wheelchairs. If someone's starting to feel like they're about to pass out or they're getting up too fast, they have wheelchairs where you can lower the head of bed, like this one. So you have time for the blood to start to rise to get to the brain. raise the head of bed, angle, transfer, be ready to lock, whatever. Change position slowly, wear thigh highs, abdominal binder, tilt table. Promote, community-based, like I said, it's a lifelong problem, they're gonna have to learn, I mean, a whole new setup at home, showers, baths, toilets. It's a, major renovation in your bathroom and bedroom, because they are gonna be living in a wheelchair, obviously they wanna be independent at home. But you have to, there is a goal of shifting from survival to like living with this, and I remember talking to my brother-in-law like years later, he's like, oh, the rehab did nothing for me, and I'm like, you had to learn how to do everything, get yourself in and out of a chair. He didn't take that into consideration, but I'm like, there's no way you could come home after the injury because you didn't know how to get in and out of a chair, just how to manage anything. So he had to, but he did, he was there for like rehab for like 3 or 4 months.